Welcome everyone to this week's Medical Grand Round at Flinders. This is the first one of 2021. As you can see, we're still doing it in a live and streamed and YouTube fashion, and thanks very much to Kay for organising that and for the programme this year, and for Andrew for doing the excellent filming. Look, we hope to get back to an audience in due course, though we might restrict it to only people that have had the vaccine, if that would encourage you all to get vaccinated soon. It's a great pleasure to introduce Professor Raj Shekhawat as our speaker today. Raj is a global citizen, he tells me. He has a background that's both Kiwi and Indian, and most recently in the UK at the Ear Institute at UCL. But he's come to join Flinders as the Professor of Audiology. Comes with, as you'll see, a lot of energy and desire to improve the world of people with hearing impairment and with tinnitus. And I think it's an area that often as physicians we might overlook. So it's great to have him here, to welcome him to the Flinders community, and look forward to hearing his update on tinnitus and some of his research in relation to that. So Raj, welcome, and over to you.
Thank you so much, Jonathan, and welcome everybody. It's lovely to be here, and it's wonderful to have this opportunity to speak to you all about some of the research which I have been doing from the past decade or so. First of all, yesterday was World Hearing Day, and this whole week from 1st to 7th March, we celebrate as Hearing Awareness Week. So I think it's really, really important for all of us to sort of pause for a few seconds and think about the significance of hearing in our lives. So I would encourage all of you who are listening to this talk right now, think about the moment you woke up this morning till right now. And try and revisit your day and think about how we depend so much on our hearing. Whether it's getting up in the morning using an alarm clock, driving to stay safe, cycling or taking public transport, attending lectures, interacting with our patients, entertainment, socialization, a lot of these things are actually hearing dependent. The very fact that I can speak 6 different languages, and I'm sure you all can speak multiple languages as well, that acquisition of speech and language, one of the primary requirements for that is to have good hearing as well. So hearing does shape a lot of us, and it does make us who we are. So also wonderfully said by Helen Keller that blindness separates us from things, but deafness separates us from people. And why this is so important? It's important because we all are social beings. It's extremely, extremely important for us to interact with people in our personal lives, in our professional lives, and in general. And research shows that social isolation can result into gamuts of health issues and mental health and well-being problems as well. And hence it's extremely important to look after our hearing. As you can see on one of the slides here, last year I was fortunate enough to give a TEDx talk about the magic of hearing. You can access that talk on the link shown on the slide or just by Googling it. In this particular talk, I was talking about how hearing is not only important, but also it's very, very sensitive. For example, if you look at the stats in Australia, there are roughly around 3.6 million people who have some form of hearing loss. And out of those people, a staggering 1.3 million people have hearing problem which could be completely preventable. Now think about that. Globally, there are 2 main reasons for hearing loss. The first one is aging, of course. I wish there was something we all could do about aging, but that's beyond our control, right? We all will definitely age. But the second one is exposure to noise. And I bet there is a lot we can do about that. If you're working in a noisy sort of an environment, construction sites, etc., it's extremely important to use hearing protection devices. But Another thing is, recently in the past few years, on the name of entertainment, we have been seeing a lot many people and even youngsters exposing themselves to dangerous levels of music by putting those earbuds in their ear and blasting that music. Now, I remember in England when I used to take train to commute, and I would often see people sitting meters away from me and literally blasting the song so I could hear what song they are listening to. Now, is that good for your enjoyment? Maybe yes. But is it good for your ears? Maybe not. So it's important to understand that our hearing system can take only certain intensity of sound for certain duration. Once we cross that limit, it can result into permanent hearing damage. So, on the occasion of Hearing Awareness Week, I would really urge everybody to be more mindful and careful about hearing. Let's all preserve it and enjoy it for a bit longer. Talk a little bit about my background. So I did my master's in audiology and speech pathology from Mumbai University in India. And after that, I had an opportunity to work clinically for a few years in Mumbai, in United States. I was in Houston, Texas. From there, I went to Singapore. I was working for a hospital setup in Singapore for almost 3.5 years. It was a brilliant exposure. It was attached to an ENT unit. And we would see lots of clients with all sort of hearing issues. And that was a time when I actually started seeing a lot of clients with tinnitus. So that was my very first encounter with tinnitus as a clinical audiologist. And it made me really, really curious about that condition. So that sparked my interest more and more into tinnitus, and I went to University of Auckland in New Zealand to do a PhD which was focused around finding novel ways to manage this condition. I was there in New Zealand for almost close to 10 years, where I worked in 2 different universities, and then I went to Ear Institute, UCL, which was a fabulous place, multidisciplinary setup with lots of amazing basic science as well as clinical research happening in all sort of aspects related to hearing. And it's my absolute pleasure now to be at Flinders University. I'm really grateful to College of Nursing and Health Sciences to sort of fly me over here in Adelaide right in the middle of the pandemic. It was quite a journey in itself. And what I have done is, I have documented this whole journey of flying in the middle of the pandemic and also quarantining at the Pullman Hotel right here in Adelaide in series of videos on my YouTube channel. So you're more than welcome to watch them as well. I would also like to take this opportunity to thank the immigration, hospitality, police and healthcare staff who are working so well together and looking after lots of people like me who are coming through and encountering quarantine here. Now, coming to tinnitus and today's topic. The slide which you can see right now on your screen, it's a dear friend of mine who suffers from tinnitus, and I remember very clearly taking this photo myself. And the discussion was that if you have to represent or depict tinnitus, how would you show it visually? So this is the expression he gave. Last month, we celebrated Tinnitus Awareness Week from 1st to 7th of February, and it's really important to understand more about this condition because it's way more common than we think it is. In the world, there are more than over 100 million people who are affected by tinnitus, and this prevalence is likely to be doubled by 2050. Now, let me share something more alarming with you all. In Australia, if you look at the cost of just hearing related issues and how much of an economic burden or costing it is causing to the health services and also loss in productivity, the number comes down to around 15 billion Australian dollars annually. Although we don't have the stats for this number specifically for tinnitus in Australia, but if you look at globally, for example, in England, every year around 750 million pounds are spent on GP consultations purely for tinnitus. And this number is massive for some of the other European countries. For example, in Netherlands, the figure is around close to 11 million euros. which is a lot. And if we look at the themes and if we look at the similar healthcare services in these countries, these numbers should be quite high in Australia as well, because 1 in 6 Australian is suffering from some form of tinnitus. When this talk was announced, I personally met a lot of colleagues right at the hospital and Flinders Medical Centre who told me and who caught up with me in the corridor saying that, hey, we do suffer from tinnitus as well, or I know so-and-so who suffers from tinnitus. So, well, this is my message to all of you. If you have tinnitus, or if you know someone who has tinnitus, there will be lots of opportunities by which you could take part in the research which is going to be happening here at Flinders University. So please do stay in touch and look out for those calls very soon. One of the most common response people get when they try and seek out for professional help because of tinnitus is this response that, well, I'm sorry, there's nothing I can do about it. You need to learn to live with it. Well, unfortunately, that's not true. There are so many things which can be done for people with tinnitus. It's just a matter of being more aware about those options. And hopefully, I'll be able to touch on some of those today. Let's look at some facts about tinnitus first. Tinnitus is way too common, as I said before. The good news is, most of the time, it disappears on its own. So, all of us will experience tinnitus at some point or other in our lives. It could be after, say, a wonderful night out at Fringe Festival, or it could be, say, a whiplash, or after a stressful time, or after some sort of medication intake, etc., etc. And mostly it disappears on its own and it's not a problem at all. However, for some people, it lingers on and it starts interfering in their day-to-day activities. For example, in their ability to concentrate, in their ability to sleep, in their ability to hear or listen or communicate properly. And that's when it becomes a bit of a problem and it requires some kind of intervention. Here we can see the psychosocial impact of tinnitus, the various things it can cause. For example, if you're constantly aware about this bothersome tinnitus, it results into this constant state of anxiety, which in turn becomes like a vicious cycle of constant awareness about the condition, and then it results into series of emotions such as anger, frustration, tension, poor communication, lack of sleep, etc. One of the common things people ask when I tell them that, hey, I do tinnitus research, is that, well, there's nothing can be done for tinnitus. There's no cure for tinnitus, isn't it? And yes, they're right. We don't have a cure for tinnitus, but we need to understand why we don't have a cure for tinnitus which will work for everybody, or why we don't have one size fit all, especially for tinnitus. So let's understand it a little bit more in detail. You can see lots of M&Ms or Skittles, as different people call them, on the screen. Now, if you type the word heterogeneity, that's one of the images which pops up on Google search engine. But the question is it really a representation of heterogeneity? Well, they look different, but they differ only by color, right? But the shape, the size, the taste, the weight, and the way they respond to, for example, if they are heated or if they are pressed, all of that is exactly similar, right? So it's not really a representation of heterogeneity, it's just differ by color. Let's look at another set of candies. These are like gummy bear candies, right? Now, if you look at them, all the oranges ones, they taste a bit similar. The blue ones, they're slightly different in taste, but all the blue ones are similar. Similarly, the yellow ones. So, but the question again, are they really representation of heterogeneity? Well, not really, because they differ only with respect to two of these features. That is the taste, right, and the color. Rest of the things, like their shape, their size, again, their response to applying pressure or heat, all of that is absolutely similar. However, let's look at this third example. These are like assorted candies mixed up all together. Is this a real representation of heterogeneity? Probably yes. However, under these assorted candies, we can identify subgroups of candies. For example, all the yellow ones which are similar, they will probably taste similar and respond similar to say heat. However, all the small blue ones, they might have a different taste and they might respond slightly differently. And the question is, why am I talking about all these candies this afternoon? And how is it even related to tinnitus research? Well, there is a little bit of relevance here. And the relevance is one of the biggest challenge we face in tinnitus research is that it's really difficult to replicate the studies, whether it's basic science studies on animals or clinical research on humans. And the another thing is, often you'll see that there is a study with no significant result, but there will be individuals who will show a significant improvement. But if you look at them collectively, that effect is lost. All right? So that's the situation. Now imagine you have study A, B, C, D, and then you have different people with different types of tinnitus, right? You have this green triangle and a green square and a blue triangle and a blue square. Imagine if you could magically put them all separately together like as subgroups and classify them as type A, type B, type C, type D, and then have a specific intervention designed for that particular subtype. Wouldn't that be wonderful? However, we are not living in an ideal world, and we are slightly far away from reaching to that point in research, because what we would need for that is large database of tinnitus patients measured using similar or instruments so that we can identify the various subtypes. All right. So now let's look at what sort of progress has happened in this area. The first one is this body called Tinnitus Research Initiative. Now, this is one of the biggest global initiative which is focused towards identifying different types of tinnitus and understanding more about this condition and coming up with various management options for various types of tinnitus. There are more than 500 interdisciplinary people involved in this research around the world under this organization, and it does series of things. For example, conducting annual conferences, textbooks on tinnitus, coming up with scientific consensus about things like definition of tinnitus or assessment of tinnitus and various other aspects of tinnitus, and also having various subgroups which are focused on specific type of intervention which is aimed at managing tinnitus. I'm really privileged to be the public relations manager for TRI, and in this capacity it really facilitates me to do a lot of scientific research information sharing and communication across people from different disciplines, for example basic scientist or psychologist or ENT or audiologist, and I think that's a wonderful space to be in, because that's the real future and present of research. Gone are the days where a single discipline can address a condition. It's the time where you really require multidisciplinary or transdisciplinary approach towards addressing complex issues. We have another initiative called European School for Interdisciplinary Tinnitus, or ESIT. Now, ESIT is a consortium of 12 leading universities in England and Europe, and as a part of this project in 2017, we hired 15 incredibly bright PhD students from around the world, and they became part of that consortium, and they have been almost at the verge of finishing their PhD research, looking at various questions and also coming from different perspective and different lenses of their own disciplines. For example, basic science questions or data mining or app development or neuromodulation and other clinical and non-clinical research questions. Most of these students are about to finish their PhD. It's got slightly delayed because of obviously COVID, but we have amazing research coming out of that project as well. And also UNITY, which is unifications of treatment and interventions for tinnitus. Now, this is one of the biggest research grant in Europe. It's for 6 million euros, which was funded under Horizon 2020 Research and Innovation Grant Scheme. Now, as a part of this wonderful initiative, we have got different people from different disciplines coming together to look at various management options for tinnitus. And we have identified 4 clinical sites where we'll be running these trials. And that's Germany, we have Greece, we have got Belgium, and we've got Spain. And you can see this is the picture from the very first meeting where everybody came together and brainstormed about various aspects of it. It's my absolute delight to be the chair of the Scientific Advisory Board on ESIT, and it represents people from patient groups, people from industry, people from entrepreneurs who come up with, say, startup ideas around app developments, etc., and working really cohesively together. And I think that's a wonderful way to explore more in the field of tinnitus research. And of course, the most important thing here is especially for tinnitus research, there is a need for more research funding, and there's a need for more and more collaboration. So if we have some ENTs who are listening to this talk, or psychologists, psychiatrists, neurologists, or people from other discipline, and if you think you might be interested in some aspects of tinnitus, please do get in touch with me. We are in the process of setting up lots of studies here, and it will be really, really nice to get your inputs and your views as well. And I'm really grateful to Jonathan as well, because he did put me in touch with lots of people, and we are coming up with lots of interesting ideas which we are pursuing very soon as well. One basic question about tinnitus, whether it's a problem of the ears or it's something to do with the brain. Now, decades back, people used to think that it's a problem of the ear. However, more and more people lately understood that there are multiple centers in our brain overlapping, which are contributing towards the perception and maintenance of tinnitus. And it is a complex condition. And hence, the solution can't be one size which fits all. One thing which we must understand is tinnitus is a symptom. It's usually associated with a condition. For example, it could be something as simple as having impacted wax in your ear, which is causing tinnitus. And once that wax is removed, the tinnitus disappears, which is wonderful, isn't it? Similarly, majority of the time, tinnitus is associated with some form of hearing damage or hearing loss. And that is why it's important to look after our hearing. Then, of course, things like head and neck trauma, temporomandibular joint issues, traumatic brain injury, ototoxic drugs, and lots of other reasons which can contribute towards tinnitus and its perception. In terms of its overall management, there are various options which are available. And the starting point could be something as simple as general fitness and wellness. If people sleep properly, people look after their diet properly, that could potentially have some implications in tinnitus perception too. But if somebody has a hearing loss, and if it is aidable hearing loss, it's a good idea to consult your audiologist and look at the various options which are available for your particular type and degree of hearing loss, and how that intervention can help you in terms of not only enhancing your communication, but also in terms of assisting you with your tinnitus. Then we have various forms of sound therapies available. There are various behavioral therapies like cognitive behavioral therapy or tinnitus retraining therapies are available. Then we have few options such as drug therapies and research tools. Now, this is a little bit of a gray area. We need more and more research in this side, and that's why they are called a research tool, because they are still at the level of investigation and gathering more and more evidence rather than reaching directly to the clinical level and being accessible to the patients directly. So one of the techniques which I'll be talking today, which is the focus of my research, is one of that research tool. And if you want to experience it, as I said, we will be looking for some volunteers in the next couple of months, so you're more than welcome to stay in touch with us. It's called neuromodulation. So we have got two forms of neuromodulation. One is invasive and one is non-invasive. The focus of my presentation is going to be more on non-invasive stimulation, and under that there are various types of non-invasive stimulation. For example, we have got this magnetic stimulation, which we call TMS, or we have direct current stimulation, and then we have a slightly refined version of it called high definition TDCS. So I'm aiming to talk a little bit more about this direct current stimulation to you all today. Before I speak directly about its use in the field of tinnitus research, let's just take a step back and understand where we sort of got this idea of trying it for tinnitus research. Now, there's work which is happening in the field of stroke management, where there was a study which was conducted by Professor Kathy Stinner from University of Auckland, where a group underwent just the physical therapy of their paralytic arm, and the other group underwent the same physical therapy, but before that they underwent one session of brain stimulation, and the results were really, really interesting. The group which underwent neuromodulation, they showed statistically significant improvement of the functioning of the paralytic arm. So it almost becomes like a priming training protocol, using non-invasive brain stimulation to almost prime the brain to respond a little bit better to the intervention which is coming afterwards. And we did try and conduct a clinical trial which was focused more on the same idea, where using brain stimulation and combining the brain stimulation with hearing aids and see how that sort of worked. And I'll be able to talk a little bit more about it later. But let's understand this technique in detail first. What exactly is transcranial direct current stimulation, or TDCS? How does it look like? What actually happens when someone has to undergo this stimulation? So on the slide you can see a client who is undergoing this stimulation. We use these big rubber electrodes which are enclosed in those sponges, which is dipped in the saline solution and then connected to this little device which delivers mild electric stimulation to the head. However, there's a slight variation of that technique which is called high definition TDCS, and contrary to those big rubber electrodes, we use those small micro electrodes which you can see on the slides, which are then placed, for example, in this slide you can see 4x1 configuration. So you have central anode which is surrounded by 4 cathodes on the person's head, and the stimulation happens. And one of the advantages of using high definition TDCS is the stimulation is more focal. It stays within the circle of those electrode dimensions which are mentioned in 4x1 configuration, rather than the stimulation becoming more widespread, stimulating the various regions in the brain. We could be more focal with high definition technique. Here you can see a client who is undergoing a high definition stimulation. You sit on a very comfortable chair. We put that little cap, put those electrode holders, and 4x1 configuration is demonstrated here, and the device is behind you. Now, one of the advantages of using this particular technique over some other techniques is the fact that you can design some really powerful studies, especially placebo-controlled trials. So the real stimulation and sham stimulation can be planned really, really well in double-blind manner. So, for example, once you start the stimulation in a conventional stimulation, the stimulation ramps up. It keeps going all the way till the duration you set it up for, and then it sort of fades off. However, in the case of sham stimulation, we do have the same initial part where you start the stimulation ramps up, and it stimulates you for a couple of seconds, and then it sort of fades off. And then there's no stimulation afterwards. And the idea of doing this initial stimulation very briefly is to replicate the similar sensations which somebody will encounter when they are undergoing that stimulation, which is usually mild tingling, itching sort of a sensation. It's not painful. I have personally not encountered any client with whom we have to stop the testing because it was uncomfortable to them. It usually results into sensations like itching or a little bit of a warm sensation, and it doesn't stay forever. It's just there for a couple of minutes and this fades off, making it really, really hard for the patient or the research participants to judge whether is this a real stimulation or is it a sham stimulation, which is really good for scientists because that's what you want when you're designing a strong clinical trial. Is it possible for everybody to undergo this stimulation? Well, we do have some inclusion-exclusion criteria, and on the screen here you can see the candidacy. So if you have, say, a metal implant in your head or in your body, if you're pregnant, if you have a history of seizures, it's usually not a good idea for you to undergo this stimulation. So that's why it's always a good idea for us from the research side of things to always look at participants, get their data, and then decide which study or which trial they might be more suitable for and offer them something similar. Here you can see some data which shows what kind of sensations people commonly experience when they undergo this stimulation. A little bit of a tingling, itching, warm sensation, a little bit of a scalp pain, but it's not really a pain which is uncomfortable or which makes them say that, oh, I don't want to undergo this stimulation. Now, coming to the physiological basis of this particular stimulation. Now, anodal stimulation, the anodal high definition TDCS or TDCS, it results in, during the stimulation, the depolarization of the resting membrane potential, which result in the excitation of underlying neurons where we are doing the stimulation, and its after effects are mediated by long-term potentiation and depression. And what happens is, often by either competition or inhibition, it tries and reduces the hyperactivity which is happening in the auditory cortex because of tinnitus perception. The very first study around the use of this technique for tinnitus came in the year 2006. So you could imagine, it's sort of like a decade and a half's time, and we are still at the initial preliminary stage of exploring this field of research more and more. So when we started looking at this particular technique, there were lots of questions around what should be the intensity of the stimulation, what should be the duration of stimulation, where exactly we should stimulate, what site might result into better tinnitus suppression. And also, if you're using 4x1 configuration, how far apart they should be, what should be the location of the stimulation, what should be the gap between the number of sessions of stimulation, etc., etc. So, in the past decade and a half, we have done series of studies investigating all of these parameters to try and optimize these parameters specifically for people with tinnitus. And what I'm going to do is I'm going to share few of those exemplar of those research studies with you, and I'm more than happy to discuss a lot more with you in detail if you're interested in this research. So, for example, this particular study was conducted to look at the optimization of the current intensity and duration of the stimulation. And we used series of different studies in dose settings in dose response manner, and we found that it was a 2 milliamp of current intensity and 20 minutes of duration which was effective for tinnitus suppression. There was this particular study which we conducted to look at the combination of hearing aids and TDCS on tinnitus, as I was mentioning to you before. Now, that was a very exciting study because when we can see that one session of stimulation can result in transient tinnitus suppression, logically you would think that, okay, if one session is resulting into some suppression, how about we do multiple sessions of stimulation and see that how they could have a cumulative impact on tinnitus perception. So we did design this study a few years back where we had, instead of one session, we did 5 sessions of stimulation back to back on 5 consecutive days, and on the 6th day programmed hearing aids, and then follow up for 3 to 6 months time. And we were really amazed by the results, that the way hearing aid was programmed especially for tinnitus resulted into really good effect on tinnitus perception. However, those back-to-back sessions on 5 days, they didn't really result into much of a difference, which was really intriguing. I mean, as a scientist, you would like to ask yourself, what happened? Why we didn't see that result? So later on, after finishing that study, we did get a chance to try and do a trial to optimize the number of stimulation sessions, because we didn't know that how many sessions would be best for tinnitus and what sort of a washout period should be there between them. So as you can see the result on the slide, which shows that the impact of cumulative session on tinnitus perception is actually non-linear in nature. So it doesn't mean that as you continue the stimulation session, the effect will keep on growing. It sort of reaches to a peak and then it starts going down. And that peak point is roughly around 6 sessions with a washout period of between 2 to 3 days. And we were like, I wish I knew that before I was planning that clinical trial with hearing aids and multiple sessions, because if I could go back in time, I would do a study where instead of having 5 sessions on back-to-back day, I would rather do 6 sessions over 3 weeks' time and then try and see what sort of an impact it would result into. And hopefully we are going to pick up this question in the coming years in the research which we'll be doing here at Flinders University. You can also see here that how the difference between conventional TDCS stimulation and high definition stimulation is different. How the conventional stimulation can result into stimulating the widespread areas on the brain. Contrary to that, if you're using the high definition stimulation, it's more focal in nature and its effects are slightly more longer lasting than the conventional TDCS. So this is the part of the research trial which we conducted and published in 2015. This was a work which was done by one of my master's students at University of Auckland in New Zealand. We aimed at identifying the distance between the electrode for optimized effect on tinnitus perception. And based on this study, we revealed that it's 3.5 centimeters should be the adequate distance between your anodes and cathodes to have optimal impact on tinnitus perception. Now on the screen you can see one of my very bright and engaging PhD student, Tori Cook, who's based at Ear Institute, University College London. So Tori started her PhD in 2019 and she's doing some really interesting work in the space of tinnitus, getting the voices of tinnitus patients heard more, and of course in the field of neuromodulation and its impact on tinnitus perception. When I came here, I did bring in a research grant with me here from England, and I'm really grateful to Royal National Institute for the Deaf and Rose Tree Trust for funding this research project for 3 years' time. And as a part of this research called, it's an international discovery research grant, I've just hired Dr. D. Domingo, who is a postdoctoral research fellow in audiology working here with us. And Dr. D is doing some really interesting work. She's planning lots of interesting studies about tinnitus, and if you or someone you know is keen to take part, probably Google Dr. D. Domingo's details and get in touch with her, and we could put you in the database which we are creating for people with tinnitus. One of the studies which we are planning, Dr. D is planning, is about COVID-19 and tinnitus. I think any research is incomplete if we not include the patients and public right at the inception stage, rather than just using them for data collection and dissemination of the research information sharing. So what we want to do is we want to understand how COVID-19 in general and the impact it has had on people's lifestyle, on the soundscape of people, social isolation, and how that is coloring people's perception of tinnitus. We already have some preliminary data from England, but we are more interested in gathering more of this data locally in Australia, and to hear more and more right from firsthand from people with tinnitus, to understand the challenges, the barriers, the facilitators they have encountered during COVID-19 period, and how we could incorporate some of their voices into the research which we are planning here at Flinders University. I'm also really grateful that in my very short span of around 6 months here, I had a chance to collaborate with lots of amazing institutions within Australia, whether it's University of Queensland, Macquarie University, Audiology Australia. Soundfair is a wonderful patient sort of an organization which is focusing more and more about equity and equality for people with hearing issues. SAMRI, right here, they have some fabulous fMRI facilities, and we are collaborating with them to conduct one of our studies, and there are lots of other patient organizations we are engaged with. So I would really like to thank all of you for giving your time and listening to this talk about tinnitus and hearing loss in general. Look after your hearing. It's really precious, so be very careful. If you have tinnitus or someone you know have tinnitus, do get in touch with us if you want to be part of tinnitus research, which we'll be doing here. And once again, thank you so much for your time.
Raj, thank you so much for that talk. As is traditional, I might try and draw you out on a few things.
Yes.
So, you said I need to protect my hearing. And
Yes.
My iPhone tells me the level that I have my earphones at.
Yes.
Is that a scientific level? Is that a helpful thing? Is that a well-informed thing? Should I take note of that?
Well, research shows that we have this concept called maximum permissible noise level, which means that you could be exposed to 85 decibel of sound levels for roughly 8 hours. Now that sounds like a huge amount of duration, right? That, oh, I don't have to worry about anything. However, the interesting thing is every 3 decibel increase in the sound intensity, this permissible duration becomes half. So if you go by that number, once you reach to a point of 115 decibel, it's less than 30 seconds of exposure, which could result into some sort of a hearing damage. So it's important to be mindful about those levels when we are listening.
Okay,
yeah.
Thanks. So I took your message about heterogeneity around the causes of tinnitus, and this issue about whether it's in the ear or in the brain. And you mentioned functional MRI studies. So
Yes.
can you, in patients with tinnitus of a brain etiology, does it light up with functional MRI?
We are actually planning to do that study here. And the idea is when we are using brain stimulation, often for anywhere between 20-25% all the way to 70% of participants, it results in the transient suppression. So what we are inquisitive about and we are going to investigate more is when they have the perception of tinnitus going down, what exactly is happening at neurophysiological level. So we're going to be putting people in scanners just before, during, and after the stimulation to understand that mapping in the brain with respect to tinnitus.
And are you trying to deliberately target the auditory cortex in a very particular way, or are you
Yes.
trying to get adjacent areas? Or?
Absolute. Good point here, Jonathan. There are 2 areas we are really interested in. One is auditory cortex, because that's where the processing of sounds happen, right? And then we have prefrontal cortex, which is underneath which we have got a limbic system or emotional response or reaction to sounds, right? So often people with tinnitus have 2 components to it. One is the loudness of tinnitus I'm hearing, and second is the annoyance it is causing. And there's some early preliminary data which shows that if you stimulate the auditory cortex, it results into suppression of loudness slightly more, and if you stimulate the prefrontal cortex, it results in the annoyance suppression a little bit more. So the idea is for us going forward is to try and combine these sites as well and see if we could have better overall impact or not.
You didn't mention it, but no treatment comes without a side effect. But does your hearing change following this sort of stimulation?
So far, I mean, there have been hundreds of people who have undergone brain stimulation, non-invasive brain stimulation, and I have personally not encountered anyone saying that their hearing has changed or not,
Yeah.
which is a good thing,
Yeah.
because it's not really noise. For example, if you're doing, say, magnetic stimulation using that coil, it does generate a lot of noise. This is very quiet kind of stimulation. It doesn't really create any noise as well. So it's very unlikely that it will result into any kind of hearing-related side effects.
Okay. Just in a very practical way, if I'm a physician seeing a patient in clinic, says they've got tinnitus, general practitioner might, what should be the first steps in considering that, and what things as a audiologist and researcher would you like us to have done before the patient sees you, for example?
Yeah, that's a very good question, Jonathan. I think if somebody is coming to, say, for example, to their GPs with a primary complaint of tinnitus, it would be really important to dig a little bit more deeper to understand how exactly tinnitus have come in the picture. Is it, for example, I had a car crash a couple of years back, and that resulted into very loud tinnitus. So in that case, it was linked with the accident, and for me, it disappeared on its own, right? So, and I mentioned in one of the slides that it usually accompanies with lots of other issues as well. If there are some of those medical issues, for example, if somebody is having a temporomandibular joint issue, they need to address that, and hopefully, as a result of that, tinnitus would be fine. It is also very important to look at their hearing, because as I said, 99.9% of the chances there is some form of hearing damage associated with tinnitus as well. So a referral to an audiologist for hearing evaluation would be a good thing as well, to try and understand it a little bit more. And also providing the right information is very important, Jonathan. The internet is full of all kind of crazy things about it. And if I'm experiencing tinnitus for the first time and I go on internet and I'm alarmed by some of the information, that doesn't help in any way, right? So pointing them in the right direction to get the authentic information about the condition can also be a big game changer too.
Okay. Raj, we might stop there. Let me thank you for your advocacy around patients with hearing issues and with tinnitus. Thank you for the research you're doing to try and improve it. And as I said, the energy you're bringing to this area at Flinders, and welcome again.
Thank you so much, Jonathan, and thank you all for joining us today. Thank you.